Welcome to today's webinar, Waiver Service Definition Updates, Questions and Answers, Session 3. During this third session, the following will be addressed: intensive therapeutic residential habilitation, community transition, crisis intervention, applied behavioral analysis, and professional assessment and monitoring, also known as PAM. Our presenters today are Mr. Lucas Evans, Division Chief Behavioral Analyst, Leslie DeGroat, Division of DD Clinical Coordinator, and Ms. Emily Levering, Director of Federal Programs Unit. I would ask that everyone please stay muted during this webinar, as well as all questions, please put in the chat and direct those questions to the panelists or presenters, not just the host, so that everyone sees those questions and can answer. All right, I'm going to go ahead and hand off to Lucas.
Excellent, thank you for the introduction. So let's go to the next slide. So the first place we're going to talk about is the ITRH. I won't say the whole name because it's a mouthful. And the question that came in regarding this service from the introduction session was, what occurs first? Does the UR review occur first, or does the approval by the Chief Behavior Analyst occur first? And what is the time frame for the Chief Behavior Analyst to review and decide? And so one of the things I want to make sure people understand is that there is no extra layer of approval for this service. The way that it will work is, once the team establishes the need for this service, and the service coordinator would just submit a request, a utilization request to UR, and then what I will do, or a designee, so an area behavior analyst, what we'll do is act as an ad hoc member of that local UR committee to be that subject matter expert to ensure that the person meets the medical necessity requirements, and then that will be our kind of quote unquote approval process for this service. So there's no additional service. Referrals for this the ITRH service do not need to come to me or an area behavior analyst for approval before being submitted to UR. We, the area behavior analyst or myself, will work with UR to be that kind of gatekeeper for the service at that time. So hopefully that helps. If there are additional questions for this service, I'll pause here and let people chat those in. That was the only one we got from the introduction. And I'll pause here for about 30 seconds. And if there aren't any in that time, we'll move forward. And if people have some after that, I'm sure we have time to circle back.
We do have one question.
Oh, perfect. Go for it.
So the packet goes to CBA and not the UR?
No, the packet goes to the UR as in any service request, and then the Chief Behavior Analyst or a designee will work with that UR committee to basically be the subject matter expert during the UR process to determine if the service is appropriate or not. So there is not an additional approval. Please do not send packets to me or area behavior analyst. Send them to UR, and we'll work with UR to look at them there. Okay, I think I saw another question come in about what the service code was for this. That actually is a really good question that I should know off the top of my head. I will have to look that up. I'm sorry. We'll get back to you on that. Or Leslie or Emily, do you happen to know that off the top of your head, the service code for the intensive res hab?
I'm looking it up right now. So if you want to go ahead, we can provide that.
Excellent. Thank you so much. Okay, so moving on to the crisis intervention service. The question that came in around this was, how does crisis intervention service relate to an individual who's under 20, who has ASD, who's waiting for state plan behavior services? And so from this, the global question that I took from it, that people are wanting to know about is, how does crisis intervention service interact with applied behavior analysis service? And so the answer to this is that crisis intervention service is intended to provide an immediate therapeutic response to somebody who has severely challenging behavior that poses a health and safety risk to either themselves, to their caregivers, or to the community, and who has a need much beyond what crisis support would be available in Medicaid. It's supposed to be a short-term service. It's reactive in the sense that it really is just focused on preventing and safely addressing crisis situations. It is not a substitute, and it is not in competition with the Applied Behavior Analysis Service. And the Applied Behavior Analysis Service would focus on intensive skill development to address the root problem of a crisis situation. So they should be able to work in tandem. Crisis intervention is really just about, how do we keep somebody safe? How do we develop strategies that prevent and appropriately respond to a crisis situation? And Applied Behavior Analysis Service is on, what is the underlying root issue here, and how do I do intensive treatment or teaching to give this person the skills so that they no longer need reactive strategies to address crisis situations. So they can work together. One is not a substitute for another. Hopefully that helps answer the question. If there are additional ones, again, I'll pause here and give answers to the best of my ability.
Okay. One of the questions is this replacing ESOS?
So just a clarifying question. Is the individual who's asking about ESOS, is that in relation to the crisis service or the intensive res hab?
Both.
Okay, so trick question. The answer is no to both. So in the enhanced system of support pilot that's currently operating is not a residential service provider or a direct service at all to a person, and so it is not the same or even related to the intensive therapeutic residential service. It's also not the same as crisis intervention service because the waiver crisis intervention service is a direct service to a person. The enhanced system of support pilot is a consultation that's provided to teams to build their capacity to safely support an individual. Waiver crisis intervention services is a professional directly supporting a person with challenging behavior. So the difference between ESOS and crisis intervention is, in crisis intervention, you're contracting with a service to have that crisis professional, that crisis clinician, or that crisis tech directly intervene with a person who is having a crisis situation and directly create a plan for that person. Enhanced system of support is working with the team to help them build the capacity to be able to safely plan and execute strategies that address a person's quality of life. It also is about helping get that team in contact with community resources that are necessary. So again, related but not the same. And I also saw a question about, how do you get this service added to your contract? I'm going to guess that that's related to the intensive therapeutic residential rehabilitation service. And the answer to that question is, right now you can't. So the way this service was added was as part of a selective contracting requirement. And so we have some specific requirements that have to be met for a provider to be able to provide this service. So not anyone can provide it. At the moment, there's one provider that's approved to provide the service. In the future, we'll be opening it up, and at that time, we'll share specifically the criteria that are necessary to be in place for a provider to be able to add this service. Just some highlights, like that includes having a behavior analyst or similar position as a clinical director, being an active tiered agency with implementation systems and data systems, and also some other requirements that have to be met. So that's a good question. More information will be available at the time that we're opening that up to start considering additional providers. That is one of our priorities. Currently, that's not what we're doing. And if it's the crisis intervention service that people are wondering how to add that to your contract, provided that you meet the provider qualifications, which are in the service definition. You would add it just like any other service that you would have on your contract. You would get in touch with PR and they could help you get it added to the contract, again, provided you meet the requirements to provide that service.
Okay, we have some more questions, Lucas.
Okay.
What does it look like in real life? Maybe an example. Does somebody come to the site?
I'm going to assume that people are asking about crisis intervention service. And yes, so the way it looks in real life is the crisis technician or the crisis clinician, as part of the crisis intervention service, is directly responding to that person.
Okay. Can a BCBA begin by providing crisis intervention services to stabilize the client, then go into the FBA from there?
Sure. If they have both services on their contract.
Okay. Do we have providers contracted to provide this service? I think you
Yes.
touched on that.
Yeah, this is not a new service. There were changes to the language, but the fact that this service exists is ongoing. It's been in the waiver for quite a while now. There are several providers that provide this service. And also to point out, some providers go to the person, so the person stays in, let's say, their ISL or their group home, and the provider goes in. Some providers choose to provide it where they actually have a site where somebody goes to, and they provide it there. So it can happen both ways. Both ways are permissible. We have providers that do it both ways, and again, this service has been in the waiver for quite some time.
Okay, Lucas, I think maybe you addressed this. I'm not really sure. For crisis intervention, your PowerPoint says accredited or certified. What is that process?
So good question. I don't see that, so I'll have to follow up on that. I don't. Yeah. So okay. So that just means certified or accredited ISLs through like MARF or other accrediting entities. So you have to actually be, if you're going to do it like in your own agency, so like you actually bring people in, the residential portion of it, the place where people live, has to be accredited and certified just like any other place that people live. So that's what that means. And again, the crisis counselor, the crisis clinical staff needs to meet the requirements in the service definition.
Okay, I think that's it.
Okay. So next slide. All right, ABA services in hospitals. So this one was part of a generic question of what can be provided in a hospital. So I went ahead and just answered it when it comes to ABA. So this is the same slide that we shared earlier, and it's just as a kind of a reminder that now with some changes to the language in the service definition, ABA services can be provided to somebody in a hospital when the hospital can't provide the necessary supports. Specifically, this is geared towards helping somebody safely transition back out of a hospital, which has been a significant barrier for folks in the hospital in the past. And so we're really pleased to be able to have this ability in the waiver now. And so this can be an additional avenue to help people who end up in the hospital that need continued behavior support to be able to receive that and also safely and successfully transition back out. All right, so the question for this one ties back into what is the community transition service? What does it encompass? And so this is again the same slide that was previously presented, and it's just trying to help people understand that community transition services for those non-reoccurring, so those like one-time only setup expenses for folks who are transitioning from an institutional setting or another provider operated living arrangement. What it does not include, so what isn't able to be reimbursed is when people go to like more restrictive settings like intermediate care facilities, nursing facilities, or when people are moving within a provider. So if you are with provider A and you go from site 1 to site 2, like that doesn't qualify. So I think I just saw several questions about ABA services in a hospital. Did I catch that right, Kat?
Yes.
Okay.
What would ABA services look like in a hospital setting?
Well, it would likely look like ABA services in a home setting. It should involve some teaching. It should involve some support of staff to successfully interact with the person. It looks like focusing specifically on some issue that's preventing the successful transition to try to remediate that direct. So the behavior analyst will be working with the person or with the support staff that are at the hospital, whether those be PA or hospital staff members, to safely support the person so they can be successful when they move. It would look like whatever is needed that falls under the practice of behavior analysis to help the person get out of the hospital.
Okay. For ABA, are there any limitations on the codes permitted to be utilized while in the hospital?
So I'm sorry, repeat that. I was looking at a different question. So they're asking which codes can be used?
For ABA, are there any limitations on the codes permitted to be utilized while in the hospital?
There is no limit on which of the ABA services can be utilized. The only caveat, which is a very important one, is that whatever the activity that the behavior analyst is providing needs to be within that service definition and not replacing something a hospital should already be providing. So what that means in practice is the behavior analyst could use service codes related to a functional assessment. So they could start or continue a functional assessment while somebody's in the hospital. They could provide treatment. So if they're already past the assessment and in the treatment, they can use codes related to providing treatment, either personally, so with protocol modification, or just services by technician, so through another RBT or an assistant behavior analyst. So that would be fine. So really any service can be used. So again, so long as it meets the service definition and it is not supplanting or replacing something that a hospital should already be providing.
I'm going to jump in here, Lucas, a little bit too. Just on top of that, not duplicate of any service that they're already providing if they're providing the ABA service.
Yes.
And from my experience, for me, I see this when you have a participant who goes into the hospital and the hospital can provide the behavioral health side for the crisis, but they may not be prepared or not have the staff to provide the actual ABA behavior analysis that a participant may need to get them successfully discharged.
Right.
And I have a question similar on that, as far as I would also think there has to be that working with the hospital to allow an outside professional to come in and work with the participant.
Yes, that's a good point. Thank you for adding that.
Okay, we have another question. So if an individual is going from an assisted living facility to an ISL for the first time, do they qualify for community transition?
Good question. I'm gonna have to take that back. That's not really my area. I'm covering this. So I will take it back to the expert and we will have an answer for you in the FAQ that comes out.
I'm not seeing any more at this moment. Oh, wait a minute. Here's one. So can crisis services be used if the hospital is not capable or willing?
That's a good question. No. So correct me if I'm wrong, Emily or Leslie, but where we landed on that is that because the waiver service definition does not include the additional language like the ABA service, so it's not an option. That is not something that can be provided in a hospital. I know that part of that original question was also could crisis intervention service be provided in a school? We are still waiting for some additional consultation regarding that. We feel like we know the answer, but we want to be 100% sure before we answer. So stay tuned for that.
Okay, so that's the last question so far. And Leslie put some answers in the chat as well to everyone about community transition services. Lucas, do you want me to read that?
It keeps flashing. I'm not seeing it. So if you could help me out, that would be fantastic.
Okay. Leslie Bradley had commented, community transition services are not recurring setup expenses for individuals who are transitioning from an institutional or another provider operated living arrangement to a living arrangement in a private residence. Provider operated living arrangements shall include any provider owned residential setting where Missouri HealthNet reimbursement is available, including the following: immediate care facilities for individuals with intellectual disabilities, nursing facilities, residential care facilities, assisted living facilities, DD waiver group homes.
Thank you, Leslie.
I think that's the last one so far.
Great. So am I out of the hot seat?
Yes.
Okay, thank you.
Okay, thank you, Lucas. This is Leslie DeGros, your division's clinical coordinator, and I'm going to review professional assessment and monitoring, or PAM, as we like to call her, haha. Anyway, new language noted in red font was added for clarification, so you can see that on the screen. The service definition and scope is professional assessment and monitoring, or PAM, is intended to promote and support an optimal level of health and well-being. And the added language is, a prescribing practitioner must prescribe an identified need for the PAM service. And that was a question that was brought up previously. Do we need a physician order for PAM services? And then I'll just refer back to that new lingo in red to help assist with that. And yes, a prescribing practitioner must prescribe an identified need for PAM. So I'm going to go on to the next slide, and please, put your questions in and we'll answer them as we go. Oh, I do see one. Shall we stop in between each slide and answer? Does that sound okay?
That's fine, Leslie.
Okay. Do you mind helping me, Kat? Let's see. Okay. For those who live in an ISL, we need a physician's order for the nursing services. This actually, PAM applies to non-residential. So non-residential services. So, and then PAM is also a short-term for assessment and monitoring. It is not a long-term thing. So if a person, I'm giving an example, pretend like I was, admitted to the hospital, and then I came home with a colostomy, and so that may be qualification to acquire PAM, bringing in a nurse perhaps to assess my situation and kind of see what kind of monitoring I need. So it's a short-term kind of a service. I'm going to go to the next slide, because as we go, we will have more information as well. So new language added on this one. This service must not supplant Medicaid state plan services or Medicare services for which an individual is eligible. Excluded services include diabetes self-management training, because that would be covered elsewhere, available under the state plan, and medical nutrition therapy services prescribed by a physician for Medicare eligibles who have diabetes or renal diseases. PAM is not continuous care. Let's see, who are potential providers for this service? That is an excellent question. I will bring that back to my group, and I know that there has been discussion about that and really looking into people who can provide the service, like how do you reach out and find someone? Because it would be an RN, it would be a certified dietitian. So let's see. Provider told me that the waiver manual says PAMs can be used for people in residential. I have not looked it up myself. I will say PAM was able to be utilized in residential, but to my understanding now, it is non-residential only. Now, anybody on the panel can correct me if I'm misspeaking, but I believe sincerely that is the case now. Excellent questions, by the way. And if I can't answer it, I will definitely take it back to my group and we will get answers for that Q&A. Okay. But aren't we supposed to use the PAM code for individuals in shared living res-hab host homes? I'm not sure if is that a continuous kind of a nursing presence that you are having in the home. I would need some further details on that, I believe, in order to properly answer that.
Leslie, hey, this is Emily. I know where they're going. I think I understand. That
Okay.
PAM
Thank you.
code is used in with a modifier, and then it is used for a registered nurse for monitoring in a group home, or there's another modifier on that T1002 code that another modifier is for shared living.
Oh my gosh, thank you.
Yeah, so it may appear that I think that's the thing in Seymour. It lists the definition and the definition is related to PAM, but if you put the modifiers on it, then you have registered nurse monitoring for group home, or another modifier is for the registered nurse monitoring for shared living, or yeah. Does that make sense? So I think that's probably where the confusion is, where it can be, it has a different name if it's in a group home.
I gotcha. Yes, thank you for speaking to that. Does that help? Does anybody want to drop in chat to see if that answered your question? I appreciate you speaking up.
Yeah, it helped with Sonia's comment too.
Yeah, I hope. Yeah.
Another question that came up is, do nursing hours in group homes and ISLs above the standard 1.25 require the prescribing practitioner as well?
Oh, I can, and I think I can answer this honestly here. That would need to go through UR. There is a process that you need to get with PR and go through UR and to be able to request more hours. There does not need to be a physician's order that I know of. I've never known that to be a true thing, but yeah. I'll definitely go back though, because we'll have this in the Q&A and I don't want to steer anybody wrong by any means.
Who is considered a prescribing practitioner?
Oh, that's wonderful. That's a question that came up, and I do have a link. Do you guys care? I would like to put in the chat if that's okay. It is a link to the State Board of Nursing, because a question that did come up was, are community or agency RNs considered a prescribing practitioner? And no, they are not. But licensed physicians, advanced nurse practitioners who work under a physician are able to do that. But I would like to put the I'm just going to send it to all attendees. Anyway, it goes to the Board of Nursing, and that lets you know kind of what their scopes are. So they are not definitely able to do that, but like our primary care provider or what have you, advanced practice nurse working under a licensed physician. Okay. And this may, I don't know if this is linked to what we were talking about before. Typically, I've seen this service authorized for someone who resides in a shared living model, for someone who, let's see, for someone who resides in a host home. Are we going to need to obtain a script from a doctor for this service from here forward? I don't believe that. Let me go back to that previous slide. Emily, are you aware, is this a major change for people who had been utilizing it for host home? Is this something new as far as having a prescribing practitioner? I'm just not familiar with host home, and I apologize.
I am not sure either, because Melissa or Leslie, do you know, with your history with Pam, that change, if it was a major, if that was a major change, or if it was?
It looks to me like it was added for clarification. So yeah, I'm not sure if it was not. I thought it was necessary before, but I'll be quiet and let Leslie or Melissa weigh in.
Sure. Which change are we talking about, Leslie?
Having the physician's order, and this is coming from a perspective, let's see, for someone who resides in a host home, are we going to need to obtain a script from a doctor for this service from here forward for the PAM service?
Leslie, yeah, that's right. It's not authorized in the host home. That's why I'm getting confused, because it's not for residential services.
Okay,
Right.
so however, maybe they were using it with that, oh, Emily, what'd you call it, with that
The modifier.
So if they're using it for a modifier, this isn't applicable to that. So however you're doing it, I'm guessing you'll still do it however you're doing it. This is for non-residential.
Right.
Yes.
Okay, thank you guys. Took a little bit for me to get my head wrapped around it, around what, yeah, the core of the question.
I think I may have confused that. It is a different, yeah, Pam is only residential. There is something else there is monitoring by an RN for group home.
Okay. I'm just kind of going through the questions.
I'm not seeing any new ones.
Okay. Thank you. And so I will go on to the next slide. Okay, change required by CMS service definition. The state revised the first paragraph statement of training when indicated to training when identified as needed for the care of the individual. So PAM is a consultative service by a licensed healthcare professional that may be utilized to assess, examine, evaluate, and or treat an individual's identified conditions or healthcare needs and planning. It may include instruction and training when identified as needed for the care of the individual. So that only change is just more of a clarification to that last portion of the statement.
So we do have something that came in, Leslie. It says, so this change does not affect those getting nursing services in residential services.
Correct. Correct.
And another question came in. If someone is getting self-directed medical PCA services, will they need a prescription for the PAM?
Can you repeat the first part of that, please?
This has to do with self-directed services. So if someone is getting self-directed medical PCA services, will they need a prescription for the PAM?
If they qualify for it, if they're non-residential, if it falls under that, then yes. It does. I'm not sure if that, I'm still learning a lot. Does that fall under non-residential, the self-directed?
Yes.
Okay, then yes.
Another, individuals who receive residential PAM, do we still need a doctor's order?
Well, what we're talking about here is non-residential PAM, and it does need a doctor's order. Whatever it was that you've been doing with PAM, if you've had the modifiers or what have you, that hasn't changed. I don't know if that answered it well, but this is a non-residential, and if you're a non-residential, fall under that category and you're qualified for PAM, then you will need a doctor's order. Are you seeing anything else, or should I move to the next slide?
We have somebody that says, can you restate that residential RN oversight is a completely separate service authorization from the PAM code / service?
Yes, yes. That is correct. It's completely different.
I believe that's it, Leslie, so far.
Okay, thank you. Oops, sorry, I went the wrong way. Okay, the state revised the following statement. This is what the statement was. This would include, but is not limited to, reporting all changes in health status to the physician and the support coordinator and providing written reports of the visit to the support coordinator. So what it was changed to was all changes in health status are to be communicated to the physician and the support coordinator. Written reports of the visit will be provided to the support coordinator. All records must be documented, or excuse me, all services must be documented in the individual record. So really, that last sentence looks like it's the main difference. All services must be documented in the individual record. Do we have any questions on this slide? Or
We do have a question that came in. It said, what is the ISL RN code used for the T1002 TD, or what is the difference from the PAM RN code T1002?
I do not have the code. It's myself for the oversight RN. The code for PAM, I'm not sure. I don't have that handy either. I do know that the oversight RN, they take care of people in residential services, typically spend 1.25 with the individual. They can request more hours, more time, more units through UR if needed, if medical situations occur. PAM would be a short term, and just like what it says, assessment and monitoring, utilized for consultation, helping get the person, after hospital discharged, making sure that they have the appropriate supports and things in place related to any changed health needs.
That's it so far, Leslie.
Okay, thank you. Okay, and change required by CMS. Specify applicable, if any, limits on the amount, frequency, or duration of this service. So the state revised the first sentence after EPSDT to include the following language, but consistent with waiver objectives of avoiding institutionalization. So the services under the comprehensive waiver are limited to additional services not otherwise covered under the state plan, including EPSDT, but consistent with waiver objectives of avoiding institutionalization. So it's another tool that we can use to help keep people in their homes, help keep them as independent as possible, prevent institutionalization.
We have another question. It's about self-directed services. For clarification, isn't the PAM agency-based service and not a SDS service, thus not part of the medical PA for the self-directed service.
I think that's one we're going to have to take back to the SDS service lead to answer that question better. Today's group is not the lead on SDS services, so it's a better question for him to answer.
Yes, thank you, Emily. I was stumped. I was about to say we need to take that back. I appreciate that. Yes, great questions though, guys. The great questions, and we will get you, the Q&A posted definitely.
Another question came in. We have received clarification from central office that shared living consumers are to have the T1002 nursing code and not the T1002 TD code, TD being the modifier. Can you clarify for shared living which nursing code is needed?
I cannot speak to that, but I can provide an answer to that once I can look that up or get that information. We can definitely post that with our Q&A.
Okay, Leslie, so far that's the last one.
Oh, and here we have the closing slide.
This would be Emily.
You can pass the thing to Emily. if
Yep.
she needs it.
So I want to thank everybody for joining today. We have a few outstanding questions that we will get answers to and post on the website on a Q&A document with a recording of this call and the slides. I believe the slides will be with it too. But most importantly, the recording will be there and the Q&A will be for any of the leftover questions that we weren't able to answer for you guys on this call. I appreciate all the good questions. And if you have additional questions, you can email them to the address on the screen here, the ddmail@dmh.mo.gov. Okay. Thank you very much, guys. Bye.